In this video I will talk about multiple sclerosis, and let's start with case study. So, 28-year-old woman came to your office complaining from pain in her left eye with blurring of vision since 2 weeks. She also stated that she had some tingling sensation in her left hand. On examination, the patient had diminished sensations to touch and pain, vibration and position sensations were diminished, knee and ankle jerks were exaggerated. The patient also had altered rapid alternating movement in upper limb. What is the possible diagnosis? Okay, the answer is multiple sclerosis. Why? Because we are talking about multiple sclerosis here. And second, because here we have a patient presented with multiple neurological lesions in non-anatomically related positions. And this is the hallmark of multiple sclerosis. You have a patient who is usually female in her 20s or 30s, presented with a history of multiple neurological manifestations in different sides of her body. On an examination, the same is seen: multiple neurological lesions at multiple sites. So, what is multiple sclerosis? Multiple sclerosis is a progressive autoimmune demyelinating disease that specifically involves the central nervous system. So, this is a disease of the central nervous system. Multiple sclerosis never ever involves the peripheral nerves. It is the most common demyelinating disease, and it is the most common cause of disability in middle age group. This disease, as I said, is 2 to 3 times more common in women, and it has a genetic predisposition, especially mutations at the human leukocyte antigen DR2 locus. So, next question. What are the most commonly implicated environmental factors in this condition? The pathogenesis of multiple sclerosis is very complex. It involves many environmental and genetic factors. But the most important environmental factors include, first, a decrease in sunlight exposure. And this was suggested from the fact that multiple sclerosis is much more common in cold countries, in the temperate zones, and the prevalence decreases towards the tropical areas. This has led to the second factor, which is vitamin D deficiency. Most patients, or a great majority of patients with multiple sclerosis, are deficient in vitamin D, but we don't know the mechanism or if there is any relation between demyelination and vitamin D deficiency. Third, we have viral infections, especially Epstein-Barr virus and human herpes virus type 6. Almost all patients with multiple sclerosis are infected with Epstein-Barr virus, but again, we cannot establish a cause and effect relationship here, because Epstein-Barr virus is very prevalent in the general population. Maybe up to 90% of the general population is infected with Epstein-Barr virus. So these environmental factors, together with the genetic factors, will trigger an immune reaction within the central nervous system that results in a breakdown of the blood-brain barrier. So immune cells, especially CD4, T helper 4, and T helper 17 cells, will attack the myelin basic protein, which is the protein that forms the myelin sheaths within the central nervous system, and this results in demyelination. Early in the disease, there will be decrease in the conduction of nerve signals. Later, however, the axons themselves will be affected by the process. Next question. What are the most commonly involved areas? So, demyelination will affect many sites in the central nervous system, but the most important include the cortical fibers, especially at periventricular regions, the medial longitudinal fasciculus, which is seen in the brain stem, not in the cortex actually. The medial longitudinal fasciculus, I will discuss it later. Also, the disease affects cerebellar fibers, it affects the optic nerves and the spinal cord, especially the dorsal column tracts. If we memorize these areas, we will memorize the signs and symptoms of the disease and the common presentation. And this leads us to the next question. What are the classical features? We said it affects the optic nerves, and this presents as optic neuritis. Multiple sclerosis is the most common cause of optic neuritis. The patient will present with pain, unilateral eye pain, with blurring of central vision. Second, we said it affects the spinal cord, and this presents as transverse myelitis. The patient will suffer from spastic paralysis, from exaggerated reflexes, from numbness, loss of vibration, proprioception sensations, and Larmet sign. Larmet sign is when the patient flexes his neck, there will be an electric sensation that runs down the body, to include the trunk and upper limbs and maybe the lower limbs. Larmet sign is a sign of cervical spinal cord compression. So it is non-specific for multiple sclerosis. It is seen in cervical spondylosis and compression by tumors or vascular anomalies. This is Larmet's sign. Third, we have a brainstem involvement. This is called a brainstem syndrome, in which the patient will present in multiple cranial nerve problems, such as internuclear ophthalmoplegia, which I will discuss in the next slide, dysarthria, recurrent facial palsy, trigeminal neuralgia, dysphagia, nystagmus, diplopia. Also, cerebellar lesions. We said it involves the cerebellum. This presents as ataxia, dysmetria, dyskinesia, which is the alteration of the rapid alternating movements, and the tremor, which is known as Holmes tremor. Common presentations, I highlighted the common presentations: the optic neuritis, transverse myelitis, nystagmus, ataxia. Tremor also is common in the presentation, and very common presentation is focal sensory deficit, such as numbness, with balance and gait problems. This is a very common presentation. This picture shows us the main sites of involvement and the main features. We have cortical involvement, which results in cognitive impairment, which results in problems with memory and mood problems. We said there is optic nerve involvement results in optic neuritis, brainstem syndrome, diplopia, vertigo, dysarthria, internuclear ophthalmoplegia. Bladder dysfunction is also common in patients with multiple sclerosis, seen as urgency, incontinence, and hesitancy. Cerebellar involvement results in a tremor and ataxia. Spinal cord involvement results in Larmet syndrome, loss of pain, proprioception, vibration sensations. Okay, that's the question. What is the most common type of multiple sclerosis? The most common type is the relapsing remitting multiple sclerosis. This is seen in 80 to 90% of patients, in which the patients will have acute attacks, but between the attacks the patient is normal. This is seen in 80% of patients. Other rarer types include primary progressive multiple sclerosis, in which there is a neurological deterioration from the start, and this is seen usually after the age of 40. Also, the third type is secondary progressive multiple sclerosis, which starts as relapsing remitting, but later it will result in neurological deterioration. And the fourth type is the fulminating multiple sclerosis, which is seen in minority of patients. Okay. Internuclear ophthalmoplegia. What is internuclear ophthalmoplegia? Internuclear ophthalmoplegia is a condition of disrupted conjugate gaze. What is a conjugate gaze? A conjugate gaze is that when I look at one side, both eyes will look at that side. For example, when I want to look at the right side, the right eye will abduct using the lateral rectus muscle, while the left eye will adduct using the medial rectus muscle. But these two muscles, the lateral rectus muscle and the medial rectus muscle, are innervated by different nerves. The lateral rectus muscle is innervated by the cranial nerve 6, abducens nerve, and the medial rectus muscle is innervated by cranial nerve 3, which is the oculomotor nerve. So we need a connection between these two nerves to establish the conjugate gaze. And this is the function of the medial longitudinal fasciculus, the MELF. You can see in the center of the image the cranial nerve 6. So let's say I would like to turn my eye to the right side. My cranial nerve 6 nucleus, which is found within the pons, will send signals to my lateral rectus, to my right lateral rectus, so that I will abduct my right eye. And at the same time, signals will pass along fibers from the cranial nerve 6 nucleus on the right side to the cranial nerve 3 nucleus of the opposite side, of the contralateral side. These fibers are known as the medial longitudinal fasciculus. Signals are sent from cranial nerve, from abducens nucleus on the right side to oculomotor nucleus on the left side, so that I contract my medial rectus muscle to adduct my left eye so that I will look at the right side. This is the conjugate gaze, and it is affected in multiple sclerosis when the demyelination occurs in the medial longitudinal fasciculus. There will be loss of the conjugate gaze. When I want to look at one side, the opposite eye will remain fixed and it will not look at that side. This is internuclear ophthalmoplegia. Next question. What is the best initial test for this patient? For a patient with suspected multiple sclerosis, the best initial test, the single most accurate test, is the magnetic resonance imaging. MRI is highly sensitive for multiple sclerosis. Sensitivity can reach up to 95%. So normally a healthy brain will look homogeneous in texture, whereas in multiple sclerosis we see whitish areas surrounding the ventricles. These are the periventricular lesions known as plaques. These plaques are non-specific for MS, but they are highly sensitive. CT is non-sensitive for multiple sclerosis. Usually these lesions are not seen on CT. So what other investigations we do? We can do CSF examination. This is not necessary, but it is helpful. It will show moderately elevated proteins, or even mild elevated proteins, so the elevation is not as high as in case of Guillain-Barré syndrome. Also, there is moderate elevation of cells, white BCs, especially T lymphocytes, but also the elevation is also mild, less than 50 cells are seen, so it is not as high as in case of infection. These two criteria are seen during an acute attack. We have oligoclonal IgG bands, which are seen in 90% of patients with multiple sclerosis, especially between the attacks. They are non-specific for multiple sclerosis, so the CSF is helpful but not necessary. Diagnosis, also there are other tests known as the evoked potential electrophysiological tests. These will show delayed response in multiple sclerosis, especially the visual tests. The diagnosis of multiple sclerosis is based on a criteria known as McDonald criteria, which is highly complicated, and I will not discuss it here. Next question. What is most important differential diagnosis? The most important are the connective tissue diseases: systemic lupus erythematosus, Behçet disease, Sjogren's syndrome, antiphospholipid syndrome. Especially these four, they present as recurrent attacks of myelitis, which is highly seen in multiple sclerosis. And the lesions of Behçet disease can be very, very similar to multiple sclerosis, so we need to differentiate between these conditions. Okay. What is the drug of choice for acute attacks? The drug of choice is high-dose steroids. IV methylprednisolone is used in an acute attack of multiple sclerosis, which is followed by oral steroids. This is usually sufficient. However, if the patient is not responding, we use a plasmapheresis or IV immunoglobulins. Now, this is used during an acute attack. What about during remissions? We want to prevent relapse. So for long-term treatment, we have first-line treatments and second-line treatments. Actually, there is a long list of drugs for multiple sclerosis, but these are the most widely used. First line include glatiramir and beta interferon. They decrease the incidence of relapse by 30%. Second line drugs include fingolimod and natalizumab. These drugs are immune modulators, so they suppress the immune response towards the myelin sheaths. What should you inform your patient when you prescribe beta interferon? You should inform him about a flu-like illness. This is the most common complication, also inflammation at the site of injection. These are the most common complications of or side effects of a beta interferon. Patient will have fatigue, fever, myalgia, headache. This is extremely common with beta interferon, so you should inform your patient about it. Next question. Before that question, I would like to say about pregnancy. Pregnancy in multiple sclerosis has a mild protective effect. There is decreased incidence of acute attacks. However, the risk is great during the puerperium. The weeks following delivery are a high-risk period. Also, the main cause of death with multiple sclerosis are renal failure from recurrent urinary tract infections and also from bronchopneumonia from recurrent infections. This is the most common cause of death. Here we have a question. After a prescription of a drug, the patient presented with worsening neurological symptoms and increased hypodensity on MRI. What is the most likely prescribed drug? And this is known as progressive multifocal leukoencephalopathy. This is a side effect of natalizumab, especially if the patient is positive for JC virus. So we should screen the patient for JC virus before prescribing natalizumab. This results in worsening of neurological symptoms because the name is leukoencephalopathy, which is a pathology at the white matter, which is the original pathology of multiple sclerosis. So I think that is all what you need to know about multiple sclerosis. Thank you.